Bon dia. Very happy. That's okay. I'm working on it. My accent's terrible though. So it's a delight to be here with all of you this morning, and I'm going to talk about breast cancer in young women. What is unique? And when we say unique, I like to kind of get a little more nuanced about that. And some things are truly unique to young women, but many of the things we're going to talk about aren't necessarily unique to our youngest patient, but they're accentuated by being young. And we know that all of the things that are accentuated are often important to older women as well, but it's just harder for some of our young patients to go through the slings and arrows of regular breast cancer care along with some of the other psychosocial and emotional issues that go. I think the most important thing, though, and one of the reasons I started focusing on this from the beginning, is that we've known for some time the relationship between survival and age at diagnosis of breast cancer. You can see this landmark study published now 30 years ago from Adami and colleagues that showed that young women have a relative survival difference at that time that was much lower than older women, all things considered. And you can see the hazards for the youngest were the greatest, especially early on. At this time, there was about a 13% difference absolute in survival for young women. And fast forward, these are the most recent SEER data that one of my colleagues pulled, and showed that while the differences are smaller now, and fortunately survival is much better than it was 30 years ago all around the world, there's still a big difference. You can see here that in the youngest women, and this is not controlled for stage or for phenotype, the youngest women are still doing the worst on average with a 5% difference in survival at 5 years. And that's just intolerable. And even though all young women and all women are doing better, we do need to fix this disparity. And in our country, as I suspect in your country and others, there's also racial disparities that intermix with the age disparity, given the demographics of young women versus older women. In addition, and I think this is what really hits us when we see our young patients, especially in follow-up, young age is associated with worse quality of life after breast cancer. Several years ago, this was shown in the Nurses' Health Study, where they looked at thousands of young women and older women, and they compared the old to the young, and they found that while physically women were doing okay overall as breast cancer survivors, the largest relative declines in quality of life were in the youngest women. And this included in the physical roles, in bodily pain, sexual functioning, social functioning, and mental health. This has also been looked at by Patty Gans, who looked at survivors who are an average of about 6 years out in California. And she found that most survivors were functioning pretty well overall, but the youngest women, the women who were between 25 and 34, were functioning the least well in terms of their vitality of all things. And there were more depressive symptoms and more negative affect in the youngest patients, and lower mental health in those patients who, in particular, who'd undergone menopause. And of course, this was back in the 80s and 90s when those patients were treated, such that many of them were getting transplanted and many of them were going through very premature menopause. And this was having a big hit on their long-term psychosocial and perhaps physical outcomes. So as I started, life can be harder for our young survivors. Not only do they deal with treatment in terms of local therapy and systemic therapy and the decisions that all of our breast cancer patients face, but they tend to have more aggressive disease and need more of the treatment. And on top of that, they're dealing with things like fertility, role functioning as young parents, or trying to find a mate, or trying to have a child, sexual health, body image issues, which are accentuated by being young. And then, of course, the emotional functioning. Younger women just don't have as much resilience. They haven't seen as much of life and built up the resilience that people do over time in general. And then genetics is a big factor for our youngest patients. And so the decisions they're making sometimes, especially when it comes to local therapy, as well as whether or not to get their ovaries out if they're BRCA carriers or another gene mutation, these can be really complicated at a very vulnerable time. So young women are a disparate population, both from a disease standpoint and from a psychosocial standpoint, and we try to kind of pick that apart and put it in different domains, as you can see here in this graphic. And the things that can contribute to disparities in general include both medical and physical differences, host differences, competing risks, the disease itself and the biology differences, as well as the care differences. So access and uptake, patient factors like adherence and social support, and then treatment differences that either come from the system or come from the patient and her system. All of these things can come together and create the disparity and that 5% relative survival difference. And so as we try to tackle it, we want to pick them apart and get at each one. And we've tried to do that in our group and working with others, and many around the world are trying to do that now, and I'll show you some recent data around that. One study that we started about a decade ago is our young women's breast cancer cohort, where we enrolled about 1,300 women, 40 and under, trying to just learn more about young women with breast cancer. And you can see here it was a lofty goal of explore the biological, medical, and psychosocial issues in young women. Really, we just said, we just don't know enough. Let's start following these women for everything we can that's reasonable and see what turns up, with some hypotheses driving it, but truly a lot of fishing going on because there were clues, but just trying to figure out what's going on, and also over time what changes. And the cohort to date has been, I think, very successful, at least recently. And I'm very proud of my colleagues who've started to publish on it, both from a psychosocial standpoint, especially early on, and also now we're doing more surgical work in it, and we're starting to look at outcomes because the median follow-up is now about 9 years, so we can look at relatively short-term outcomes, but still outcomes. And we survey patients, we collect blood and tumor, and we follow them. And we were initially following them for 10 years, but we recently re-upped to follow them for another 10 years, and probably at 20 years we'll ask them, can we still follow you? So we can really learn about what it means if you're 35 and you get AC. What does that mean for you when you're 50 or 60? And that's something we really haven't known very well, or going through very premature menopause. So it'll be a nice resource in the future. What we showed early on, though, when we tried to look at whether it was, for example, worse to get breast cancer when you're 25 versus 35, because that was kind of the lore in terms of the disease, was that it actually wasn't that different. When you looked across age groups in the young age category, the youngest women weren't more likely to have any of the poor risk features, except tumor necrosis, which we're not really sure why that is. That was the only one that came out as statistically significantly different in the very young. And again, we tested a lot of different things, so it could just be spurious that we found it. But what we did find was that, as one might expect, and as we knew anecdotally, younger women are more likely to have HER2-positive breast cancer than historical population-based older cohorts, as well as grade 3 disease. And the majority, in contrast to what people think, everybody thinks young women are just getting triple-negative breast cancer. Not true. About 60% of our young patients have ER-positive breast cancer, and so the hormonal issues are big time for them, especially in their survivorship. This was validated subsequently by the California Cancer Registry, which is one of the first registries in the United States and across the world that actually included HER2 in the routine testing of the patients in the SEER-based registry. And what they showed was very consistent with what we saw in our cohort, which is not population-based, so we couldn't be sure that it wasn't just referral biases from the centers that were included, was that, sure enough, there do appear to be more HER2-positive breast cancers in our youngest patients. Of course, there are more triple-negative breast cancers in our youngest patients. And when you look at the ER positives, they're less frequent, although they are the majority. And when it's been looked at in other settings, when you look at ER positives, they're more likely to be the luminal Bs in our youngest patients compared to as you get older, they're more likely to have the luminal A, or the grandma's tumors, as I like to call them. So if we focus on those SEER data again and look at the HER2 population, now that we bucket our breast cancers into subtypes, how are young women doing compared to their older patients? And these are data that do control for some of the factors that predict outcomes. And you can see here that when you include just HER2 patients, actually the youngest women seem to be doing just as well as older women. And in fact, it's the oldest women that are doing the most poorly, probably due to undertreatment more than anything else. That's a subject for another lecture. We'll get Rachel Friedman here next time to talk about breast cancer in the elderly and some of the things that are going on there. When you look at this in the NCCN database, which we had the good fortune of doing a few years ago, this was also true, that when you control for tumor subtype and you compare apples to apples, meaning HER2 old, HER2 young, there doesn't appear to be a significant effect of age on outcomes. And that's good news. And what that means, I think, is that we can, and this is also from the HERA trial, very similar, that age was neither prognostic nor predictive for early recurrence, at least in the HERA trial. And I think what that means is that we can use some of the evolving strategies for women with HER2 positive breast cancer regardless of age. So we shouldn't be afraid to give a young woman the TH regimen if she has a small node negative breast cancer. And of course, we're going to give her more aggressive therapy just like we would an older woman who's tolerated if it's a more aggressive HER2 positive cancer. So I think these are really nice data to help inform care, and that the principle should be regardless of age, at least in the HER2. Obviously, you're going to do something differently if they're hormone receptor positive with regard to their young age. When we've looked at the triple negative and ER positive HER2 negative subgroups, in the triple negative, the young women are also doing a little bit worse. And in the ER positive HER2 negative, the young women are actually seeing the greatest disparities in our most recent SEER data. So I think this is where the real wiggle room is in terms of mitigating the disparity, where we really need to start making a dent and try and figure out what's going on. And there are some clues. These are data from the NCCN, again, where ironically, I just told you that the luminal A's appear to be less frequent in our young patients, but that's where the greatest age disparity is. The youngest women appear to be doing the worst compared to their older counterparts. You can see, 1.7 hazard as opposed to the lower and not statistically significant ones in the other disease groups. I don't have HER2 on here, but it was not statistically significant. And there still are luminal A tumors in young women. So what's going on there? Are the women not taking their therapy? Are we not giving them chemo that they otherwise might benefit from? Or is it inadequate ovarian treatment? I'm not sure, but I think that's where the clues are, and that's where the directions that we should be heading. Finally, are there true tumor biology differences in young patients? Well, we do know that there are not dramatic amount, but an increased number of germline mutations associated cancers in young women, right? The hallmark of a BRCA1 carrier is to get a young breast cancer, right? And so there is absolutely some of that, and that's exciting because we now have the PARP inhibitors, at least for women with metastatic disease, and I know there'll be more targeted therapies along the way, and maybe it'll also benefit women in the adjuvant setting, which will disproportionately help young women. What about other gene and biology differences? It does appear that there are different proliferation signatures in younger versus older women. And there's some really provocative research coming out of different labs around the world that are looking at the immature mammary cells and the relationship between tumor progenitors and mammary stem cells and all kinds of growth factors that might be different in young women compared to older women, particularly with regard to postpartum breast cancer. What's going on in the involuting breast that does that epidemiologically known for many years, increased risk of breast cancer that occurs in the first few years after a baby and then settles down. And obviously, if you have an early pregnancy, you have long-term protection. I don't think we understand all that biologically, but I think that could be a clue to both early detection and even some avenues for prevention, ultimately, if you could prevent some of the stem cells from going awry and causing those rare but still very serious breast cancers that can occur in young patients after a pregnancy. So lots of work going on there, and we'll stay tuned on that. These are just data that my colleague Nick Wagley and Ada Wachs put together for looking at our young patients in our cohort. And as one might expect, there are more BRCA mutations in our young women's cohort, but there are also more other genes. We did whole genome sequencing. And this is compared to the TCGA. And you can see it's fairly consistent with the very young patients in the TCGA. So if you look at the oldest women, you see about not even 10% are germline carriers of the usual suspect, gene mutations that can increase the risk of breast cancer. But if you look in the youngest women, it goes up to like 25% on average. We found 24%, TCGA found about 26%. So that's pretty compelling. And again, as we get smarter about predicting who is going to develop breast cancer, that has avenues for prevention, And also, if we can target these things, it's better for treatment. So young women will hopefully benefit from that. We have also looked at very early data looking at somatic gene alterations, and there was not any clue to any big biologic difference seen in the luminal Bs, the HER2s, or the triple negative subtype. So we're comparing, again, apples to apples. It doesn't appear that there's big differences. It was interesting that the luminal A subtypes did appear to have some differences. So there was a decreased risk of having a PIK3CA mutation, which in this setting actually confers a better prognosis. So it would speak to maybe women with luminal A's being younger, doing worse. And then ARID1A, which is a tumor suppressor type gene, it appears to be increased. I'm not sure we all understand that, but mutations in it are increased, which also could portend a worse prognosis for young women. No other real clues when they get controlled for multiple testing. So again, stay tuned on that, some early data, but I think we are seeing there may be some signal for some different biology in some of the youngest patients. Can we improve the translational understanding even further? I alluded to this already. I think it's exciting and provocative and not ready for prime time with regard to the changes after a pregnancy in particular. Clinically, however, we do already capitalize on one of the most important and most differentiating thing we see in our young patients, which is their very premenopausal status at diagnosis. We've known since the SOFT trial proved it fairly clearly, the benefits of ovarian function suppression, especially in our very young patients. These are the data to inform that. And on the flip side, we also know that from the SOFT trial, and we know this now from many studies that have looked at age and adherence, the youngest women were most likely to discontinue their ovarian suppression compared to the older ones on the SOFT trial who were suppressed. It's a small but statistically significant difference. And then we also know for years that hormonal therapy adherence matters, right? If you don't take your drug, it's not going to work. And we and others have shown that the youngest patients are at the highest risk of non-adherence. So, there may be biology differences, but there are very clear issues with regard to care. And some of that's coming from the system and some of that's coming from the patient. And we need to figure out ways to manage that such that our patients get the treatment they need so that they don't have bad outcomes. So why are young women less adherent? Our group and others have looked into this, and there are a number of factors that have been borne out, not that consistently, and it's been really hard to also target non-adherence and improve it. Don Hirschman just had a big study that was negative where they tried to improve AI adherence in SWOG with text messaging and reminders and motivational messages, and it didn't work. But we know for young women that it might also be a little bit different. So yes, the usual suspects, disparities in race, lower education, lower income, receipt of radiation, which I don't understand. We see all the time women who are afraid of side effects are not going to take their drugs quite as much, feeling less informed, you probably aren't as motivated. And then finally, negative emotions about endocrine therapy, which is kind of probably related to all of them. These are all big drivers in why young women aren't taking their drug. And so how can we get in there and try and fix that? And we're working with some behavioral scientists to try and help change their mindsets about it and manage their psychosocial concerns. But the big one that's different in young women is fertility. We're all familiar with the data that suggests that fertility is a big problem in our patients. If you take care of any of these patients, you know it. We found that it drove decisions even in about 30% of patients in terms of their adjuvant therapy. And so many, including ASCO, are working on helping young patients to preserve fertility through and beyond cancer. I think some of the most exciting data have been the fact that we can now use ovarian suppression to preserve menopausal status and potentially fertility in our young patients through chemotherapy, and so that now is becoming an increasing standard. And then finally, the positive trial is something where we're trying to study whether or not it's okay for a woman with ER-positive breast cancer who's taking adjuvant endocrine therapy to interrupt the endocrine therapy to have a baby and get back on. Because if we preserve fertility, are we going to let them? Are we going to support people to have babies? Super important issue for these young patients, especially the ones that are diagnosed in the OB suite when they were trying to get pregnant. So this study, is this open here? Do they may have positive open? Do we know in Brazil? It's a study that's almost closed, so that's okay, we'll have the data. But it's a prospective study to evaluate the safety of interrupting endocrine therapy. We're accruing 500 women internationally, and they take up to 2 years of a break to get pregnant and then get back on their endocrine therapy. And we're looking at not only disease outcomes, meaning that they do worse, because we know we have a long trajectory in terms of risk of recurrence in patients with ER-positive disease, but do they also have reasonable reproductive outcomes? How easy is it for them to get pregnant? And then how are they doing psychosocially? Does it, especially for the women that try to get pregnant and don't. So we're studying all these issues, and I'm excited to say that we're almost done with accrual. We should be done in the next year. So we'll report back to all of you the results, hopefully. Finally, what else is unique for young women? Not that many things, to be quite honest, other than the things I've talked about. Most things that apply to older women should be applied to younger women, although we do try and tease out with each data that come along from new studies, should it be applied differently than young women? I've been part of this international guideline panel led by ESO, and we meet every 2 years. There's another one coming up in Lugano if anybody's interested in 2020 to kind of distill the data and apply it to young women. And the bottom line is that most things are very similar, except some of the things we've talked about today. So in conclusion, there are a number of issues that are unique to or accentuated by being young that we should focus on and pay increased attention to. I think in particular the behavioral stuff and the psychosocial concerns, helping our young women manage their symptoms, making sure they know there are options. I've had people who I've put on ovarian suppression, given an AI to, and then they don't tolerate it and they don't come back. And I could have given them just tamoxifen and they might have felt fine. So we have to make sure it's a conversation, that we make it clear that if you're having a hard time, come back and see me. There are choices. And I think improved understanding will lead to improvement in their ultimate outcomes, not just how they feel, but how well they do from a disease standpoint. Thank you.
Nós temos tempo para 2 perguntas da plateia. Dr. Barrios.
And thank you for the nice presentation. The question regarding what we know about physicians, because let's take the example of pregnancy, for example. How well informed are the physicians in order to address this very difficult issue with the patients? Are we really giving the right information and stimulating the patients that they can or they cannot stop therapy for a while in terms of having a baby? How much influence do we give to the risk perception we have in terms of their outcome in that regard? And has this been addressed? Have we sent questionnaires to physicians and see how much impact that has in terms of what happens to a patient in terms of fertility and pregnancy, for example?
So of course you ask a terrific question, Carlos. And I think we are part of the problem and part of the solution as physicians. Of course, everybody in this room knows everything now that they need to know to take good care of their patients. But yeah, it's a really important issue that we both sometimes don't know the answers because they're not known. And I think the positive trial will inform some of the, is it okay to take a break for a little while, right? We do know that the data to date suggests that having a baby compared to not, women don't appear to do worse, but many of those data are old. It's not controlled, randomized controlled trials, and there's the healthy mother bias in those. But to address the issue of how do physicians do in caring for the patients, Matteo Lambertini actually did a very nice survey study at the consensus guideline meeting where you had people who were very interested in being there for young women. And he also did a similar study at the St. Gallen meeting 2 years ago. And it showed that there's a lot of heterogeneity with regard to physician understanding of all of these issues. So it's important to be paying attention to it, to be able to know where the guidelines are. If you don't see a young breast cancer patient every day, to at least know where to turn to for what's standard, what's okay, what don't we know, and is really just a conversation with the patient and kind of a negotiation of, is more better for treatment, or is that going to ruin this lady's life? And do you make, if she's not high risk in terms of her breast cancer, maybe we support her to do what she needs to do.
Because just as a very superficial perception, okay, I feel that this is something we need to educate the oncologist a lot more than we have so far in terms of being able to orient the patients correctly.
Yeah, so there's both education and then there's also paternalism, which is well intended, and we all want to see our patients do well from a breast cancer standpoint, but we also have, patients have autonomy, A, and then B, in breast cancer, we know that we overtreat the many to help the few, especially when it comes to adjuvant chemotherapy. And now we, of course, have genomic expression predictors and things that can help us to not give chemo. But if we're going to give it to anybody, we're typically giving it to our younger patients too. So trying to kind of navigate that and stepping back and saying, it's not my life as the physician, it's her life as the young person, and helping her to make the best decisions for her with the most information you can give her, I think is critical. And that's hard, to suspend your own biases as a physician.
And from a practical point of view, the young patient that plans to have babies, what do you do before starting either neoadjuvant or adjuvant chemo? Do you collect ovarian tissue or embryos, or do you suppress the ovarian function before starting chemotherapy on all your patients?
Yeah, so I think that's a great question. So lots of options. Have the conversation. A lot of it depends on both their risk of their disease, what they're going to get treated with, as well as how old they are. So if someone's only 25, I will typically let them do everything and not bank eggs or embryos. I might suppress them through chemo because it's unlikely to hurt them, few more side effects, because they're not likely to need the embryos in the future. You're unlikely to send, with modern day breast cancer chemotherapy, you're not likely to send someone into menopause unless they're on some experimental protocol or we start transplanting people again. And so in that setting, I probably wouldn't do anything. If you're in your mid-30s though, and your fertility is already going to start, going with time, that's when or even early 30s, especially if we want them to wait a couple of years, I'll send them to the reproductive endocrinologist if you have the time to bank eggs or embryos, and then sometimes we'll add in the ovarian suppression for treatment as well, and do it through chemo to help prevent premature menopause. But it's always a conversation, and it's in the neoadjuvant setting, it's particularly hard, because oftentimes you don't have that much time. And there's data that says, you can get them banked in 3 to 4 weeks. And sometimes it takes us 3 to 4 weeks to get someone on a research protocol or get them started with their chemo. So it's not that much of a time, but if they're getting preoperative therapy, sometimes they're high enough risk that it's worrisome. And so it's a real balance with how important is it to you. And some patients will say, I'll let the chips fall where they may and take my chances. And some will go through the IVF and you just try and get them through quickly. Yes, so Dr. Barrios just brought up the part about making sure it's a multidisciplinary team, especially including the fertility experts in your team when you're trying to make these decisions. And I would adding social work or mental health providers, because this is, for infertility is very stressful. Breast cancer is very stressful. Throw these two things together and these poor young women get clobbered emotionally.
And for your young BRCA mutation carriers that undergo prophylactic ovarectomy, what do you recommend? Do you give hormones?
Yeah. So, but for fertility preservation, obviously, you're going to want to have them go through freezing of eggs, embryos, ovarian tissue, if they're having them removed, if that's something that they're interested in doing. Often, I'll have them have their children before they get their ovaries out, if you can make that happen time-wise. And most of the time in my practice so far, I have. And then, of course, they can do, if they want to and feel comfortable with it and it's available, they can do pre-implantation genetic diagnosis to try and select embryos that don't have the BRCA gene. Giving them back hormones when they go through premature menopause, you try and, I think, get them to the place where they would have been. And so if you had an ER-negative breast cancer and you didn't care, say they're a BRCA1 mutation carrier, you let them have their period again because you're not treating them with endocrine therapy, and then now they're going to get their ovaries out, there's no reason not to give them some hormones to make them comfortable through that period of time, and then obviously wean it over time. And they may be even at less risk than your average person because they don't have breasts often anymore, at least in the US, because most of them are doing bilateral mastectomy, for better or worse.
Ok, thank you very much.
Thank you.
Próxima sessão.